I'm Dr. Antonatos, a board-certified internal medicine physician focused on obesity, metabolic care, and GLP-1 treatment. My thyroid is fine. My doctor checked it. Usually what that means, TSH was measured. One number. The pituitary signal was documented, and the conversation moved on. Here is why that's incomplete. The thyroid axis runs from the hypothalamus to the pituitary to the thyroid gland, and then to every cell in your body. TSH is the pituitary signal telling the thyroid to produce more hormone. What most labs never check is what actually arrives at your cells. Free T3, the active form. TSH can be perfectly normal while free T3 is low. The combination happens regularly and it matters significantly for anyone trying to lose weight. These symptoms of subclinical hypothyroidism are easy to attribute to something else: fatigue despite adequate sleep, weight gain despite dietary effort, brain fog, cold intolerance, hair thinning, slow digestion, unexplained elevated cholesterol. These are not dramatic signs. They accumulate quietly, and because each one has a dozen other possible causes, patients carry them for years without a thyroid evaluation. Here is a composite case I see regularly: TSH 3.8 normal. Check done except free T3 is 2.1, below optimal. Free T4 is the low end of normal. Reverse T3 is elevated, likely from caloric restriction or chronic stress. TPO antibodies are positive, meaning this is autoimmune in origin. Hashimoto thyroiditis. None of that appears in a TSH-only result. The complete thyroid panel includes TSH, free T3, free T4, TPO antibodies, and thyroglobulin antibodies. Reverse T3 is a research biomarker. The ATA does not recommend it for routine clinical use, but it provides context in patients with suspect conversion dysfunction. Together, these 5 or 6 tests tell you that TSH alone cannot, whether the cells are receiving adequate active thyroid hormone or whether the cause is structural or autoimmune. What does underfunction actually do to your metabolism? Research measuring basal metabolic rate in a hypothyroid patient versus euthyroid controls show a gap of 200 to 400 calories per day at the same body weight. That is not a minor variable in a patient working on GLP-1 therapy and trying to lose weight. An unaddressed thyroid issue quietly erases a significant portion of the caloric deficit being achieved through medication and behavioral change. What this looks like in practice: a full panel, not a single TSH. Interpretation in the context of weight loss resistance. A TSH of 3.8 reads differently in a patient who cannot lose weight than in a patient with no complaints. Identification of Hashimoto before any treatment decision, an acknowledgement that weight loss itself changes thyroid function, TSH and T3 shift during active loss and need to be rechecked as the program progresses. TSH alone is not a thyroid panel. If weight loss feels harder than the math predicts, the thyroid is worth looking at properly. Thank you for watching.